Good morning, community of Griner Physical Therapy and beyond. I am Seth Griner, the owner of Griner PT, where we are specializing in outpatient therapy services for orthopedic and neurological conditions. We have a specialty in working with people with Parkinson's disease. I'm a certified rock steady boxing coach and have been coaching in Hampton Bays with the Center for Parkinson's through Stony Brook Southampton Hospital. And I'm also a certified GWR therapist. I love working with this patient population, and so does our guest. We are interviewing today. We are very lucky to have Dr. Corrine Moore as our spotlight guest interview. Dr. Moore is an associate professor of neurology at Stony Brook Medicine. She is the director of the Stony Brook Tourette Association of America Center of Excellence and associate director of the Stony Brook Medical Scientist Training Program. That is quite a resume, Dr. Moore. She graduated from the Tri-Institutional MD PhD program. That is a lot of coursework.
Yes.
And completed her neurology residency at the University of California, Los Angeles. So Dr. Moore has a wealth of knowledge, and she's going to be able to share some of that with us today, and we're super excited about that.
Thank you for having me, Seth.
Yeah, absolutely. I think one of the things in your bio that struck me most is you say that you're committed to delivering personalized care for people with movement disorders, helping them achieve the best possible quality of life. That really struck me because I think it shares the same vision and mission that we have in our clinic of catering to each individual's limitations and providing not really cookie cutter services to this population because it doesn't work for them. We know that people with Parkinson's need really customized levels of care. And because we share that passion, it really was a reason for me to welcome you to the show and try to do this interview. So thank you for coming on today.
I'm happy to be here, Seth. Yeah, I agree that we share a similar approach to our to management and treatment of individuals with Parkinson's disease, and I'm really happy to be here.
We've been in touch about patients that we treat together, that we share, and I really appreciate that we have that interdisciplinary communication. I think it's lacking a lot, but it's really necessary in managing these patients between a care team. So I really enjoy opportunity to talk about shared patients, and we look forward now to sharing your knowledge and expertise as a neurologist and movement disorder specialist with our community through this discussion. So welcome to the program.
Thank you.
So first, we got a few questions for you to get to know you a little bit better and get our patients and clients to know you better. We're just so curious, what made you decide to become a neurologist?
So oddly enough, I did not start medical school planning to become a neurologist. In fact, I really did not. I was not attracted to neurology at all, or to the idea of neurology when I started medical school. I thought I was going to be an internist, and it was only in my third year of medical school when I was doing a neurology rotation that the light bulb went up in my head that this was going to be my path, that neurology was going to be my path. So, and I distinctly remember one patient that I saw when I was in the inpatient service who had a gait disorder, and the gait disorder improved in what seemed at the time as a magical way after the team did a spinal tap on him. And so it turns out that this individual had a gait disorder called normal pressure hydrocephalus, and his condition was able to improve after a surgical procedure. And that, it just made me fascinated by the intricacies of the brain, and also, it made me realize how much we as neurologists have the potential to improve the quality of life of our patients.
That's great. I can see the passion. Your face lights up when you talk about and tell that story. And I think that's wonderful. I think that's what keeps us motivated and excited to come to our jobs each day and work with the patients that we do. So neurology is a very broad specialty, but you have a a specialty within neurology called a movement disorder specialist. Can you tell us in the audience a little bit more about what sets a movement disorder specialist apart from a general neurologist when it comes to managing Parkinson's disease?
Sure. So as a movement disorder specialist, that means that I've undergone a number of years of training. So I have done the 4 years of medical school, and then 4 years of residency, including 3 years in neurology. And then in addition to the neurology residency, I completed a fellowship in movement disorders. So I had additional years of training where I learned how to treat, diagnose, as well as treat Parkinson's disease and other movement disorders.
Mm,
So you learn to the subtleties about the diagnosis and the management of Parkinson's. And then as somebody who is a movement disorder specialist, the large majority of the patients that I see have Parkinson's disease. So I continue to gain experience and expertise in managing individuals with Parkinson's disease. So I can, compared to a general neurologist, I'm able to differentiate between different types of movement disorders. I'm able to better create a personalized treatment plan
mm,
for a given individual. And and I'm able to put together a comprehensive and provide a patient with a comprehensive care team and sort of be at
right.
the center of that comprehensive care team.
Yeah, so you mentioned education level is one that sets you apart. Being able to do a differential diagnosis, because sometimes these diagnoses overlap and it's hard to decipher and name it accordingly, and that's really important. Creating that personalized treatment plan. I know that for a lot of patients that we share, you're able to tweak their medication dosage or timing, or tweak which medications they're going to take, and that is also really key because not everybody responds well to the same medications with the same disease. And so that makes it, I think, really complicated to manage. And you need an expert like yourself to be the one who's the point person for doing that. And then you mentioned the care team, right? So there's a person with Parkinson's might have speech therapy, occupational therapy, physical therapy. They might have some cognitive deficits or need some emotional help with a psychologist. So there's so many people to coordinate and know who to refer to and when. And you have a great handle on that. And that's why I love working with you, because the patients that we share have those things in place, and not the ones that sometimes don't have a movement disorder specialist may not. So we
Mhm.
really advocate at our practice that all patients with the diagnosis of Parkinson's see, or questioning about if they have that, do see a movement disorder specialist. So thank you for sharing that with us. When somebody comes in and you've determined that they likely have some of these signs and symptoms, how does it go? How does that conversation go where you're informing them that of your opinion that they have a diagnosis of Parkinson's disease?
So I usually start by explaining how I came to my diagnosis. So I want everybody to not just hear that that I'm giving them the diagnosis but to really understand why I'm giving them the diagnosis. So I will point out that I, for example, noticed a particular tremor when they were walking, or I noticed some slowness when they were doing a particular task. And so I'll show them the signs on their neurological exam that are consistent with that diagnosis. Many patients with Parkinson's, they will also have non-motor symptoms, so other symptoms that may have predated their Parkinson's by many years.
Right.
So they may have lost their sense of smell, and they'll tell me, oh yeah, I lost that 20 years ago.
Mm,
Well, that is oftentimes seen in people with Parkinson's, or
right.
they may tell me that they act out their dreams and they punch their spouse. Diagnosis of Parkinson's disease. And then I think after explaining to them the fact that I've come to this diagnosis, for many people, this is a life changing diagnosis.
Hmm.
But I stress to everybody that they can have an impact on the progression of their disease. So I want everybody to leave the appointments with that knowledge. So I stress really that there are certain behaviors that are associated and that can slow down the progression of Parkinson's disease, notably exercise. And that it's, very important from it, right from the get-go to start to work towards having a regular exercise regimen, because we know that that can slow down the course of the progression of the disease.
Yeah, I like that you present some objective information, and share that with them, because I think that's important, because a lot of patients don't know what you're testing or why, and then that you're empowering them with the knowledge that they can be an active participant in fighting the disease. I think that is something that we stress in our Rock Steady classes for sure, and I'm glad that they're leaving those appointments, which are upsetting, with some bit of hope that they can have an impact on it. And I think that goes a long way. So I appreciate you doing that at the time of diagnosis. Makes a big difference for sure. I think a lot of people have trouble understanding like the how part of Parkinson's disease, or maybe this is just me, I'm fascinated with it. Maybe I should have gone into neurology and movement disorder specialist. But could you explain how Parkinson's disease, maybe for our general public who are non-medical folks, how that causes the typical motor system symptoms they might notice with this disease, such as a tremor or a masked face appearance or a shuffling gait pattern? What in the brain is actually causing that? I think people might want to know.
Okay, so I'm going to try to make this,
Yeah,
describe this in 2 minutes or less.
sure. Yeah, the
So
quick version.
yeah, the quick version. So we know Parkinson's disease, it's a neurodegenerative disease.
Okay.
So that means that there is the loss of cells in the brain,
Right.
and there is the loss of particular cells in a part of the brain called the substantia nigra pars reticulata. That part of the brain is
Spell that. Spell that. No.
that part of the brain is part of the basal ganglia.
Mhm.
Basal ganglia is termed the motor control center of the brain.
Got
So
it.
that is what is controlling movement. So these cells that undergo neurodegeneration in Parkinson's, these cells usually are producing dopamine. Dopamine is a important chemical that helps to facilitate movement.
Right.
And so now when there's the death of those dopamine producing cells, then we get impairment of motor control, and then patients can experience the symptoms that we typically associate with Parkinson's. So the slowness of movement, stiffness of movement, tremor.
Right. Yeah, that is definitely the case. Sometimes people will come in to the office and they're like, what's going on? How's this? Why is this happening? How come I can't move?" And one analogy that it seems to work for me, and they get it, is like, I'll say, well, like your the basal ganglia, like the ignition switch, and then the rest of your body is the car. And sometimes there's a problem at the ignition center, and so the dopamine medications can help get that started, or the exercise can also help to get that ignition switch going again. We need to start the signaling to get you to move more. And they're like, oh, okay, that kind of makes sense. So it's really that ignition switch and the signal that is the problem in these patients. And then you can see all these different types of motor symptoms, and that's what fascinates me, is like which pathways that goes on. But that's probably for another discussion on another day. But I appreciate that explanation.
That's a great analogy too. I think I'm gonna start to use
So
that also.
yeah, go for it. Because most everybody has a car, or most people have driven, so
Not sure I understand how my car works, but
maybe now you will. Just look under the hood and picture a brain. How do you approach? You talked about telling people about the importance of exercise. What would you say some of the benefits are? You tell them that's important, but how do you, if they're like, what's in it for me? What are some of the benefits that you share for exercise and physical therapy for patients with Parkinson's disease?
I just really stress that the large number of studies that have been done
Yeah,
that show that exercise slows down the disease, and that we don't have at this time any medications that I can prescribe that are going to do that. In the future, that may change. However, at this time, the best thing that a patient can do for themselves to slow down the course of their disease is exercise. And
right.
I really stress that, and I tell them that it is as important, if not more important than taking a medication. I'm going to say as important. Um,
Sure.
yeah, as important as taking a medicine, and that they should put it in their calendar and schedule it and make sure that they follow through. It can be hard. Many patients with Parkinson's do have, and this comes along with the disease, a lack of motivation.
Hmm.
But going to physical therapy can be a good way to also get them started
Right.
with exercise, and get into a routine. They know that 2 days a week they will be going and working with the physical therapist,
Right.
and the physical therapist can give them exercises to get them going. And for some people who maybe were not as, not into exercise before,
Yep.
can or maybe a little bit deconditioned, can sort of get them conditioned so that they're able to do the exercise not only with the physical therapist, but also once they leave the PT office.
Yeah, I think the PT is really responsible for making sure that that patient knows what to do, right? Because a lot of times when I've talked to people, they're like, heard I'm supposed to exercise, but I don't know what that means. Like, do I go to a yoga class? Do I go to ride a stationary bike? How fast do I go? So I think our role as PTs is to dose it appropriately, right? How much can this patient tolerate? We know what the exercise recommendations are, but that doesn't always fit each person, right? So you have to personalize it. Somebody comes in and they're totally deconditioned or never exercised in their life. I cannot get them started on a 150-minute a week program because they're never going to do that, right? So
Mhm.
if we try to get them going, what can you do? Can you do 20 minutes a week or 15? I will take whatever they're willing to meet me on, and then educating them that the higher intensity we go, the better it is for them. And the research backs that up, to moderate and high are good, but high is best. And not everybody can do that when they first start. We have a number of people that have started really low and then worked up to medium and now are doing high, and they love it. They feel their ignition switch turning on more after they do that high intensity. The volume in our classes when they start out is low, and then by the end is higher. So we know that we're getting more dopamine circuits fired up, and the more frequent that we do that, 4 to 5 times a week, is better than one or two. So I love that you're on board with exercise and getting people in at the PT to do that. So we appreciate that. Can you share a story or example of a patient who made like significant gains from engaging in regular exercise, like what you saw in their progression from maybe when they were diagnosed or at any point along their treatment stages?
So I mean, I have so many examples in my head when you ask that.
Yeah.
Yeah. So, and I have a large number of patients who I've been seeing for 5 or 6 or 7 years, who I feel like they have not progressed, or they've really progressed in a very minimal way.
Hmm.
And a large part of that is I attribute that to their commitment to exercise.
Hmm.
So I have some individuals, so I do have some individuals who run marathons, who do
Yeah,
triathlons.
that's awesome.
And not everybody is able to do that. But I also have, those individuals who are very committed to spending that 30 or 40 minutes on their Peloton bike every day.
Yeah.
And that is something that I think many people can work up to. And I've it's remarkable because they will come visit after visit, and we'll talk about our favorite Peloton instructors, and then they will, and I don't see a change in their in their disease.
Yeah.
There
So
are,
like,
it may be more complicated than that, and it's probably more complicated than that, but I am pretty certain that the fact that they have this commitment to exercise is contributing.
yeah, that's amazing, I think, for people to hear that people with Parkinson's are participating in triathlons or marathons, and maintaining their current level of function with exercise. And that I think the aerobic portion of the exercise is the unifying factor in a lot of these studies that we see. We make sure that, from cycling studies to boxing to high intensity interval trainings, that seems to be the factor that is crucial, that the heart rate is elevated to a degree that is enough to get the release of chemicals in people's brain that help to nourish the healthy neurons that are there, right? And keep them maybe some bit of preventative care from progressing the dopamine cell loss. So I'm happy to hear that you got some of those folks, and that you're challenging each other on Peloton rides. Like, that's great. I'll be in class with the focus mitts and feeling some of the punches. This is a non-contact class, so nobody's hitting me anywhere but my mitts or the heavy bag, just so everybody knows that boxing class is non-contact, but is it quite intensive. But they're hitting on my hands, and if I am not there with them and I turn and look away and see what else is going on, I get hit in the nose. And these men and women are punching hard because I'm asking them to punch hard. So you have to be aware and know where they're coming from, and make sure you're not getting hit in the nose, because I've asked them to push it hard, and they will. So
And they love your class, Seth.
yeah, I love the class too. It's a great place for people to feel that they can celebrate their wins, right, and focus on what they can do versus, the deficits that they might have. So that's something that I learned from that program, from the Rock Steady program. We try to bring it into the clinic also, because that mentality is empowering for people. And when they feel empowered, they're more likely to then go and continue with that mode, and they feel better about themselves. So the psychosocial aspect of the class, the fact that there's multiple other people in the class doing that, is empowering also. So I've had new people come into the class and look around and go like, I can't do this. And they'll see somebody who maybe doesn't walk as well as them or move as well as them, but they are working hard in the class, and they go, well, I guess I should do that. And so that group dynamic is a powerful thing, and we can't wait to have you come in the class too. We've got a
I,
nice set of
yeah,
gloves for you ready. So
I am waiting to have that day off so that I can
good.
head out to Hampton Bays. So,
Awesome.
yeah.
We'd definitely make that happen, and I know the group would love to have you, guest boxers. So we get a little more clinical. A couple things. There's a lot of times that I'll tell people that there's no two people with Parkinson's that have exactly the same presentation or symptoms. How does your medical management vary between patients with different like subtypes of the disease? Say someone with like a motor dominant type of disease versus like a postural instability, where they're more off balance, or any of those subtypes. I guess how does that vary when you're seeing them?
Right. So that's a very complicated question also. So you should have become a neuroscientist, Seth. Are you
Okay.
clearly
Hey,
looking?
there's still time. I'm
Yeah.
44. I have it.
So yes, so there are different subtypes of Parkinson's, but how you actually subtype Parkinson's can be rather complicated
Yeah.
because it can be based on, whether you got your Parkinson's at a young onset versus
Right.
later on in life. It can be whether you have a genetic form of Parkinson's
Mhm.
or a idiopathic or non-genetic form. And then you brought up that there can be different motor different motor subtypes. So whether people can have more prominent tremor or more prominent stiff slowness or more prominent balance issues. And and those whether you're in a certain subtype can change. So sometimes people can initially have tremor
Yeah.
dominant Parkinson's and then later transition to be more what we call akinetic rigid, or more of a
Right.
slowness subtype. And so my approach is just to look at the patient as an individual,
Yeah.
and personalize their treatment as,
Yeah.
so tremor, we tend to use the same medications for all of our patients. If somebody has more balance issues, I might send them to be that more vigilant at really encouraging working with physical therapy,
Yeah.
because I stress fall avoidance. We don't want to wait until after you have the fall, and really fall prevention.
Yeah.
We want to be very proactive about preventing falls before they start to
Great.
occur.
So education is
Yeah,
a big part,
yeah.
right? Telling
Education
somebody
is huge.
you've
Yeah.
got this type. This is what you need to do because of this type, and knowing that there are different types. There's very similar medications, but different combinations of them, I would say, right? Because
Right. And a different response that might be expected. So
yeah,
just sort of setting up that expectation for patients, that, for example, the medications can, for some people, be better at addressing slowness than at addressing tremor.
right.
So just so that they, so to, yeah, to address their expectation and prevent frustration when they are not seeing a symptom getting better.
That's really helpful. And that's unique to, I think, a movement disorder specialist. I don't know of a general neurologist who would be able to decipher that. A lot of times, like, oh, it's just Parkinson's. It's like, no, now I'm seeing, I don't know how many subtypes. Like, you could just keep going because
Mhm.
there's different, but
Yeah.
that every patient needs that individualized management, I would say.
Yeah.
That's crucial. So there's some new technology out there that people are talking about more. It's being used more, the technology of deep brain stimulation or focal ultrasound. These are less conservative, right? This steps up the level of care, to reduce Parkinson's symptoms. So deep brain stimulation involves brain surgery, right, and an implanted device in the chest and a lead that can help to regulate some of the symptoms. And focal ultrasound, I'm not as familiar with exactly how that is done, but who are ideal candidates for like either deep brain stimulation or for like a focused ultrasound procedures of the patients with Parkinson's disease.
Great. So those are generally considered as treatment options for patients who are more advanced. So not typically for early stage patients, but patients who've had disease for, say, at least 5 years or so.
Okay.
And deep brain stimulation is a procedure that's been around for over 20 years. So we do that here at Stony Brook, and we patients are considered potential candidates when their medications are not lasting the entire time. So when
Right.
patients are having what we call motor fluctuations or off time, where they feel the medicine wearing off,
Sure.
and not lasting the whole day. Patients can also be candidates if they have what we call dyskinesias. So those are the extra writhing-like movements.
Mm.
Many people are familiar with that type of movement. They associate it with Michael J. Fox. And for some people, that movement can be not bothersome, but for some people, that movement can be very bothersome. And when patients start to experience that, we also can start to consider them as a candidate for deep brain stimulation.
It's helpful because I think a lot of patients are intimidated by that, but it's becoming more commonly used, right? And I think earlier than it was maybe 10 or 15 years ago, before patients are at like an end stage, it might be something more in a middle stage, right?
Yeah, I would not view that as a treatment for individuals who are at end stage. I
Right.
would view it more, you need to have disease for at least 5 years, and
Okay.
you need to have what I just
Sure.
described, but it can allow patients to feel on the entire, 24 hours a day, 7 days a week. So it can be really a life-changing procedure. And I have to say that, the large majority, if not all of my patients who have undergone that procedure are very positive about having had it done.
Yeah, I think from on my end, seeing them in the PT office, instead of having these bigger swings of fluctuation of motor symptoms with larger doses of medication, they're now taking a smaller dose and more their symptoms are kind of progressing like this. I need a whiteboard right in front of me here, but
Yeah.
you guys get the idea that and they're, I would say, for the majority of them, really happy that they had done that procedure. So some people are very intimidated by it, but it's definitely something to discuss with your care team to see if you would be a candidate for that. So you get more of the information. So
Yeah.
that's my
And you point out that most people are able to reduce medicine, and along with reducing medicine comes reduced side effects from the medicine.
yeah.
So, that's also a plus.
Do you have any patient success stories that stand out to you and highlight the importance of a comprehensive, like team approach for for management of Parkinson's disease, where you had to include other healthcare professionals or make those recommendations for?
Yes, so I have a couple of examples again in my mind, and a number of patients that I have shared with you, Seth,
Yeah.
where I think that having that team approach and that back and forth between hearing from you and from my own exam has informed how we will go about the treatment plan.
Right.
I think it's really important to have a good relationship with the physical therapist, a patient's physical therapist. I've had other physical therapists get back to me after I make a medication change, and they'll tell me, the patient really deteriorated after that
Hmm.
medication change. The patient themselves
Hmm.
don't get back to me, but if
Yeah.
the physical therapist, and then I will know, I'm seeing patients every 3 months or every 6 months. Whereas a physical therapist, you're seeing them a couple times a week
Yeah.
sometimes. So it's another set of eyes, and a set of eyes that has a little bit of a different expertise than I do.
Hmm.
So it's, I think, really invaluable.
That's great. And there's a number of patients that have other services as well, right? Not just
Yeah.
physical therapy, but occupational therapy or speech therapy for swallowing difficulties or hypophonia, which is like in a low voice, right? You might notice those. Or so and the person who coordinates that is the movement disorder specialist. Like I can make a recommendation for somebody to see another professional, but the movement disorder specialist is the one who can write the referral for that. So we really value your expertise in recognizing who needs what service and sending them out for that and being in touch with us, because a lot of times we don't get that from other referring doctors. They don't make the time to do that, and I find that it's been a huge difference in how the patient is doing in their therapy and their confidence level in their care team, and then they feel confident in themselves. So I really thank you for responding to those emails and being a part of our team approach.
Mhm.
Any last things that you would think would be helpful for somebody who's considering seeing a movement disorder specialist? What would you advise them of?
I would just advise not to hesitate about that, and you don't need to wait to see a movement disorders specialist until you have, X number of years of Parkinson's disease or advanced Parkinson's disease.
Mhm.
It's really can be, as I think you've highlighted, also very helpful from the early stages
Yeah.
to see a movement disorders specialist when you are, when your primary care doctor thinks that maybe you have signs of Parkinson's disease, when another neurologist has diagnosed you with Parkinson's disease, or when Googled and you think you have the symptoms of Parkinson's disease, where I am happy to see somebody at any of those times.
Yeah, we definitely agree that the sooner you can get diagnosed, the better, so you can get access to the resources that are available. The Center for Parkinson's Disease through Stony Brook Southampton Hospital offers a wide variety of programming for patients and caregivers, support groups, painting classes, art classes, singing classes, dance classes, boxing classes. These are offered in person and on Zoom. So the earlier you can get a diagnosis, the sooner you can participate in those programs. Those are free. They're sponsored by a generous donor and is just an amazing community resources, which is unique to the east end of Long Island. So I just want to make sure everybody is aware of that because we want you to be able to use those resources. So Dr. Moore, what is the best way for patients to get in contact with you if they have a condition that they think needs examining? Who is there a phone number that we can
Sure.
give out to our listeners?
Sure. So I can the telephone number for Stony Brook Neurology is 631-444-2599. And then I can also provide you with a telephone number for our movement disorders coordinator, whose name is Erin Harrabies, and her telephone number is 631-444-3448. And she can also help to facilitate getting an appointment and getting in to see us.
That one is good for me. I will definitely share that with patients. We'll talk more and get maybe their email address so that I can facilitate getting people in to see you. I really enjoyed speaking with you, Dr. Moore. This was great. I think our patients will really take a lot out of this interview and hopefully get themselves or someone that they know who might have symptoms of Parkinson's disease in to see you and your team. And if there's any other ways that we can help, we will certainly be in touch. Thank you for this time and opportunity.
Thank you for having me, Seth. It was
great.
Thank you for having me, Seth. It was